Let's take a look at a guided implant surgery case where a patient presented with tooth number 31, which was missing for a long time. And asking the patient how long it's missing, he stated it was many years. So I took the patient through a cone beam CT scan, obviously a comprehensive exam, and I wanted to fabricate a guide for a guided surgery. This guide was fabricated based on a intraoral scan and a cone beam CT scan. And once we fabricated it, I was able to go ahead and seat it on top of the adjacent teeth. This is what we call a tooth-supported guide, and I was able to go through the protocol of creating the osteotomy. So initially, I want to go ahead and remove the soft tissue, so I'll use a tissue punch, and once I have access to the surface of the bone, I'll go ahead and go through my osteotomy drills. With this system, we're using a spoon and a sleeve to guide each one of our drills. So we'll go step by step in order to create the osteotomy. So each one of these steps is very important because each drill is in order, and you want to go through each one of these drills within that order in terms of creating the osteotomy, so you can have a very nice and clean site to place your implant. So step by step, we'll go through our pilot drill and eventually widen and deepen the osteotomy to the point where we can go ahead and deliver the implant. In this scenario, I went ahead and utilized a Hahn implant to place for our patient. And once the osteotomy is created, I can actually go ahead and connect the implant to what's called an implant mount. The implant mount allows us to deliver the implant through the surgical guide. So there's a step where we go ahead and connect the implant mount to the implant, and then we can go ahead and place that through the guide. Now you can either use a hand driver to place the implant, which I'm doing in this situation, or you can use your implant motor, and also you can utilize that to place the implant. So a couple of different techniques. It's really with the preference. I like to use a torque wrench to place the implant because sometimes if the osteotomy site if the bone quality is a little bit denser, I like to be able to back out and repeat and replace my implant several times in and out of the osteotomy site until I get it to the proper depth. So here we get a picture of the implant in position. And once the implant is in the correct position, I'll go ahead and place a healing abutment. Healing abutments come in different heights. So usually I like to measure the tissue, and I select the implant height based on how much soft tissue I have and where I want that soft tissue to end. So here you get a nice picture of the radiograph with the implant and the healing abutment in place. And the patient goes through a period of osseointegration, usually 4 months, and in this situation it was 4 months. And once the implant is fully integrated into the bone, I'll go ahead and remove the healing abutment and place the impression coping. We're taking a traditional impression. We also have the option of placing a implant scan abutment to be able to scan the implant and also the adjacent teeth for a final impression. This method here, we're utilizing the traditional medium body for the implant and the soft tissue and the adjacent teeth a little bit, and then I'll go ahead and pick everything up with heavy body impression material. This impression material will set, and within a few minutes I can go ahead and remove it, and I'll check and make sure that I captured all the vital structures, and then I can go ahead and get an impression of the maxillary arch and a bite registration and send that to the laboratory for fabrication of a final restoration. So I have all the information sent to the lab, and the lab will fabricate a final restoration. In this situation, it is a screw-retained Bruxer crown, and I'll go ahead in the next visit and remove the healing abutment once again and seat the implant crown. And just like the delivery of any other crown, I want to check my mesial and distal contacts, and I also want to check my opposing. With the implant crown, when it's screw-retained, I'll go ahead and torque the final delivery screw to 35 Newton centimeters, and then deliver the final restoration with some Teflon and some composite. So everything is sealed up, And then I'll go through and I'll check the occlusion one more time after my assistant cures the composite on top of the implant. So here we have a nice before and after picture with the guided surgical protocol and delivery of the final restoration. And in this situation, unfortunately, we have a patient who came in with an implant in the area of tooth number 30. And as you can see here, the implant was placed very well. And the patient had a stock healing abutment with a cementable crown. And in this situation, unfortunately, it seems that there was some cement extrusion, and that's probably why this implant ended up having so much bone loss. And as you can see in this picture, there is the ring of cement that you can see at the junction of the stock healing abutment and the final restoration. So the procedure was pretty straightforward for me. I had to go in and actually remove the implant and provide the patient with a little bit of bone graft in the area. Once the implant was removed, I moved forward with the bone graft. I went ahead and opened a flap, placed bone graft material, in this situation, again, some BioOs, and let the patient heal for about 4 months. So at the 4-month period, as you can see the progression of the healing, I brought the patient back in for the implant placement visit. A flap was created in the site, and you can see that the bone had healed and the patient could receive a new implant. So I went ahead and moved forward with creating my osteotomy for this implant. The implant that I am replacing the previous implant with is the Hahn implant. Utilizing a cone beam CT scan, I was able to measure the exact size of the implant that I wanted to utilize. So I'll make my initial osteotomy, and I'll use my parallel pins to make sure that I'm in the right direction and the right angulation. And once that's confirmed with the radiograph, I'll go ahead and finish creating my osteotomy completely with different size osteotomy drills, moving up in size essentially. And once the osteotomy is fully created, you can appreciate the occlusal view of the osteotomy. I'll go ahead and place the implant. So the implant is placed, and usually I like to look for a higher torque value to determine the stability of the implant. The implant is in place. I'll go ahead and place a healing abutment, and then I will suture the tissue around the implant and the healing abutment. And again, essentially, I'll go through a period and I'll wait about 3 to 4 months before bringing the patient back in for a final impression. So 2 interrupted sutures are in place, and I'll go ahead and try to create primary closure as best as I can in this situation to help with the healing. And again, a series of occlusal pictures shows you the healing process over time. And once the implant has gone through a period of osseointegration, I'll bring the patient back and remove the healing cap or healing abutment, and I'll seat the impression coping. And again, at this stage, I'll have my assistant take a radiograph to confirm that the impression coping is seated properly, and hopefully it is, and I'll go ahead and move forward with the final impression. Usually I like to utilize a medium body polyvinyl siloxane material and then pick that up with a heavy body. The reason I don't like to use light body, again, is because of the movement of the impression coping and the implant analog within the impression. So I want to make sure that I have a more solid material, stronger material to hold on to the impression coping. So once I send that to the laboratory, in this situation I prescribed a Bruxer anterior actually. So this material is the Bruxer anterior block, and it was milled right here at Glidewell Dental Laboratories. And it is strong enough for a posterior restoration with the flexural strength of between 650 to 800 megapascals. So I was comfortable creating fabricating a final crown with the material, and I went ahead and torqued the restoration into place and placed Teflon and composite. And I'll go ahead and check the occlusion and make sure that I have the crown out of occlusion slightly. So there you can appreciate the occlusal and buccal view of the restoration and the final radiograph of the implant in place. If you'd like more information on the Hahn implant, please visit our website, and there is a lot of educational information on the implant and the utilization of different dental materials such as the Bruxer anterior restoration.